Welcome to the Natural Ways to Avoid Back Surgery. In this 30-minute webinar, Dr. Cianci will explain several natural ways to avoid spine surgery. Whether you're dealing with neck and back problems, sciatica, or constant lower back pain, you'll come away from this webinar with the information to help you choose a treatment path that can work for you. There will be time at the end of the webinar to ask questions, and the webinar will be recorded and available on the website within a few days of filming for you to rewatch at any time. With that, let's get started. Dr. Cianci, over to you.
Thank you, Jen. What I thought we'd do, we have a lot of things to cover in a short time. What I want to do is list some things that we hear from patients with regard to neck and back problems. I will tell you that we're going to focus more on the lower spine, the lumbar spine today. It's more common, but the overall descriptions kind of apply for both neck and back. So some of the things we often hear, or a patient or potential patient may have heard in their history or some other care they've had, someone may have told them they have a disc problem. They may have been told they have spinal arthritis, maybe a bulging disc, a herniated disc. Maybe they have some degenerating discs in their spine. Again, they may say, someone may have said, oh, I think you have sciatica. Sometimes you hear words like stenosis, pinched nerves, spinal degeneration. These are all things that people hear. And if we've touched on any of those that you've ever heard of, either yourself or whoever you're listening to this webinar for, then it's worthwhile staying on and listening to some of the other things. So some things that kind of make someone a candidate for various types of care in our office. Maybe they've had physical therapy that failed, or they've had physical therapy that worked 3-4 years ago. It's not working as well now. Maybe a person has tried different medications. They could be prescription, they could be non-prescription, but they've tried many of those. And again, maybe they worked before, they don't work now, or it takes a lot more of the drug for them to get comfortable. Maybe they're just concerned about liver and kidney problems, which most of the painkillers affect. Certainly there's addiction too as well. People are real concerned about that these days, as well they should be. So maybe they've had steroids. Maybe they've taken some oral steroids where maybe they started off with 6 pills a day and then they went to 5 and the 4 and the 3 and the 2. It's called a taper, if you will, maybe for 5 or 10 days. And again, maybe that worked before, it isn't working now, or some people don't like the side effects of those, even if it's short term. Oftentimes people may have had injections in their spine. They could have not worked at all, or maybe one worked. They've had 3 or 4 since that haven't worked. Maybe the doctor who's administering those is kind of concerned. They don't want you to have too many of those. These are all things that you may have heard if you're a patient or a potential patient. Maybe you can't ride in a car as long as you'd like to. People say, well, you know, I ran into a gentleman the other day, someone of a friend of mine out publicly, and I said, well, aren't you going to Maine this year? You go to Maine every year, you go bird hunting. I know you've done that for many years. You and your wife go. It's kind of a yearly pilgrimage, if you will. You've done it since you were young. He said, no, I can't do it this year. I had to cancel my trip. And I know how much he loves it. And so we talked a little bit. He's had some of what I listed, back and leg problems that have been going on for years. He'd been through some of the situations that I listed earlier. And again, each one of them had kind of failed. It wasn't working as well as he'd like. And excuse me. So again, I know what you mean when we talk about a person not being able to sit and stand for a while. Let me just take a sip of water real quick. Please, excuse me. So getting back to that patient, here's something that he absolutely positively loves to do. He looks forward to every single year, and has for many years, and he's not able to do that. So we start to see activities be affected with people. Maybe they moved here to play golf 3 days a week, and they can only play once a week, and then they're miserable the entire time. So certainly activities start to be a factor. You know, I ride in a car for a period of time, and I can barely stand up when I get out. That's how this gentleman I spoke of earlier, who goes to New England every year, Again, it's a long ride. He said his ride just from his home to where we met, which was 15 or 20 minutes, he had a hard time riding in that amount in a car. And again, very frustrating for him and many of the patients that we see. Again, travel becomes a real problem. The holidays are coming and he's saying, God, I have to get on an airplane and fly somewhere to go see some relatives. And I just dread that. I dread having to do that. I dread having to ride in a car for a long period of time. My job requires me to work and sit at a desk all day or sit at a computer all day. And again, I'm unable to do that for as long as I'd like to. We hear things like, you know what, my daughter and I go shopping every year. We go Christmas shopping. It's kind of a big event. We go shopping. We have a nice lunch out. We go shopping some more. I don't know if I'll be able to keep up this year. Again, we see more and more and more an effect on a person's activity level. And very often that's what drives them here. And hence is our focus here. Maybe their legs just hurt. Maybe they say, well, I feel like my legs are going to give out. I have the hardest time, rising up from a seated position. Maybe there's been some talk of surgery. Maybe someone said, well, if this doesn't work, maybe surgery is the next option. Or maybe as you've talked to a surgeon and the surgeon's like, no, you need spinal surgery. I encourage people who come in to actually do some research on spinal surgery and look at the success rates and certainly the long-term success rates. Most surgeons will usually tell you what the possible success rate is. And I can just tell you it's not great. And it's certainly not great if you say, well, I'd like to have this surgery to hopefully fix things. It may not give you what you want after that. You can have a successful surgery that doesn't allow you to do activities that you really love and care about. So hence the reason why we kind of approach this in a multifaceted approach, if you will. There's a variety of different techniques that can be used. One of the things we're going to talk about is spinal decompression. I happen to be sitting at a spinal decompression table. We've just laid it up here much like a desk. That's where we're going to probably focus the majority of our time is going to be on spinal decompression. It kind of covers all of the whole gamut, if you will. A person who needs spinal decompression is a far end of the spectrum, had a lot of problems for a long period of time, quote unquote, the worst patient scenario that you'd like if you were the patient. But that's one of the scenarios that's used here, one of the techniques. We also use cold laser here. That's another non-surgical technique. It works with the body, if you will, to decrease inflammation, speed up healing. Fascinating stuff. I've seen some remarkable results with that. We also have I've designed over the last 32 years, some of the best rehab protocols. I find that some of the general other things that are done, just generalized abdominal strengthening and just generalized rehab that often patients come in that maybe that the rehab or the physical therapy didn't work. So we have more kind of detailed rehab. That'd be the third one. And then the fourth option we'll mention from a non-surgical approach is general chiropractic care. We have patients come in with some of what I listed before, and oftentimes the chiropractic care alone will take care of it. And our guidelines that we use to select patients for various protocols, again, sometimes it may be devastating a person's life, but maybe it's something simpler, one of the lower level things we do that may end up helping that person, or maybe a combination of those four that I mentioned. Either way, we'll cover the entire gamut if we focus more kind of on the spinal decompression aspect. So a couple of things I'll go over so you understand what's happening inside. So many of the patients that walk through our doors have been through a lot. Very often they're confused. They don't know what the problem is. They may have not seen their MRI or have anything explained to them. They may have not had their x-rays explained to them. One of the things I'll talk about is this model here in front of me. And basically, it's a degeneration model. I'll just talk briefly about it. Another thought process in our office is to keep things simple. We're not going to try not to use a lot of big terms that confuse people. Again, vertebra, here's vertebra. The middle is a disc. And the bottom is vertebra 2 as well. There's a nerve that comes out the hole. It comes out both sides. Not going to get into too much detail, but you can see that from a side view, if you will, what that looks like. This is a big, thick, healthy disc, big, thick. What happens is a person's spine very often gets out of alignment. Slowly over time, it rubs and rubs and rubs, and you can see the disc getting thinner and thinner and thinner. You can see the nerves kind of get withered over a period of time. This is the degeneration model. If you want to call it spinal arthritis, you could, but very often, person that ends up here, we'll see on their x-rays, we'll see this progression. Another thing we'll try to illustrate here as best we can with a camera is big, thick, healthy discs. They're fully hydrated, they're thicker, and slowly over time they tend to degenerate. Some people will mistakenly say, well, isn't that just normal aging? Well, we don't see this in 24 segments in the spine. We generally see it in a couple, very often mainly in one area. And we basically target that area when we're doing different types of care. But that's what happens. It's kind of a progression. It's not normal. It's common, but it's not normal. Again, getting back to our simplicity idea, if you go away on vacation and the sponge is in your sink, this is what will happen to it over time. You come back, it'll be shriveled up, dried up, and not working like a sponge should work. It often will almost crumble, if you will, because it's dried out. The only way to get this sponge back to working like it should be is that you would put it underwater and use your hand maybe to pump fluids in and out, and slowly over time, the sponge would return back to normal like a sponge should work. Again, this is what ends up happening. Here's a normal sponge. It's hydrated and working like it should be. This one bends and moves like it should and flexes. This one's stiff and doesn't move. It's the best simple example I feel like I can give you to say what happens to the discs in your spine. As they move in this direction, they're stiffer, they don't move as well. Sometimes the fluid inside will leak out over time. We'll talk more about that in a second, but that's essentially what can happen in this progression from one side to the other. Another thing that we'll show you here is a picture, if you will, zoomed in on the spine. I'm going to do my best to look at this and point the proper direction. But again, we've got vertebra, again, vertebra, disc, vertebra, disc, vertebra, disc, the whole way down. The yellow are the nerves. What very often will happen is over time, much like that sponge, things shrivel up and dry up and the spacing comes together. What also happens is the disc will push out the back. Again, in line with simplicity of explanation, if you take a jelly donut and squeeze it, jelly comes out the hole. That's essentially what happens to these discs. When they get squeezed, when they get compressed, the disc, if you will push back on the nerves. So again, the spacing comes together. So what needs to happen is it needs to decompress. It needs to separate those surfaces. You need to create more space back in here where the nerve is. That's what ends up, that's what needs to happen. It's the reason why someone who sits a lot, they're in gravity, who stands a lot, they're in gravity, will end up having problems. It's also the reason that their activity level gets affected, because there aren't many activities that you can do that aren't in gravity, sports and things like that. You get out of gravity somewhat when you're lying down, but most people want to stay healthy, mobile, and active. So that's what has to end up happening. That's a little diagram that shows it. Getting back to the far end of the spectrum, getting back to the decompression, spinal decompression. We have the table here in front of us. I'll explain a little bit about how that works. Again, the table has two sections to it. The patient is attached to the top and the bottom section of the spine, of the table, excuse me. A computer decides what needs to happen to help separate the spacing, cause some spacing between the vertebrae. Very comfortably, very easily. If you come by the office and look in a room, the lights happen to be out, very often there will be a patient on a decompression table. And the reason why the lights are out is because, again, it's comfortable, it's relaxing, and people will often doze off during it. So I'm going to exaggerate the motion here with my hands just so it's visible on camera. But essentially what happens is the computer will decide, I'll just make some numbers up here. We're going to take this patient, we're going to pull 20 pounds of pressure on the spine for a minute, and then 7 pounds of pressure for 30 seconds, and then 20 pounds of pressure for a minute, and 7 pounds of pressure for 30 seconds. There's essentially a protocol that happens while the person's on the decompression table. Comfortable, easy, they're on it 12 to 15 minutes at a time. Generally, they have a program, if you will, that helps to rejuvenate the joints, rehydrate them. And again, it goes back to the same thing when we talked about the sponge. You put the sponge underwater and you pump fluids in and out of it, and that's how it goes back to returning more towards normal. It creates more space, if you will. That's what this table ends up doing. It essentially works the joints in such a way that they take on more fluid, it creates more space, and it gives place there for the nerve to be. Most people who investigate it or want to do it don't want to think about having a bone chiseling away bone, or having part of the disc cut out, having nerves burned and things like that. Again, people who are listening to this webinar are more inclined to do those things, more inclined to do something non-surgical than surgical. So that's kind of an intro of that. We've covered most of what happens with people. There are on our website some articles that have been written specifically. We happen to have 3 of them here. There's 3 different ones specifically on decompression. Again, that's the far end of the spectrum. We cover a lot of bases if we talk about decompression. There's a whole bunch of other different success stories there of people having various other different techniques with the laser, with the rehab, with the generalized chiropractic, or a combination of those other options. But again, they're there. Certainly you can look through those if you need to have more information. So people want to know what exactly would happen if I thought maybe some of what Dr. Cianci's listed so far. What would a first visit be like? What's included? What happens there? One of the first things that happens is we get a real thorough medical history. Do you have diabetes? Yes or no? Surgeries you've had, cancers you've had, what your mother died of, your father died of, anything in the history that you might give to any other doctor, we're going to have that real thorough history. The next thing we would do is, and getting back to what I mentioned earlier, is we're going to be looking at what is it that brought you here? You want to golf and you can't. You want to get on the floor and play with your kids or your grandkids. You can't do that anymore. You want to play tennis. Whatever your activity is, we work towards focusing on that so we know what's important to you. But we spend a lot of time on that too as well. Our doctors will. Sometimes patients will bring an MRI with them. That's fine. We have a very, very thorough evaluation process here, which I'll get into in a minute. And certainly looking at some other testing you've had done is part of that. But we have some pretty interesting technologies here, which I'll talk about in a second, that allows us to see what's happening so that we don't miss anything, that something hasn't been overlooked. We also tell patients that after we've taken this thorough history, we will very often, doctors will take the chart and flip it over. And the reason for that is that we don't want them looking at it, the doctors. We want the testing to tell us what exactly is going on with the patient. And later that night, we'll review the history with the testing. It's a way to stop. I've been in practice 32 years. I've seen thousands and thousands of people. I could easily say, I got it figured out already. I know what to do without even looking too far into it. I'd rather not do that. I'd rather have the testing prove it. Getting to the testing after the history, we then have some specialized nerve testing equipment here in the office. And if people are local that are listening to this webinar, I can bet it's testing that you haven't had done elsewhere locally, because I don't know of anyone in the area that has the instruments we have to measure nerve function. But there's some specialized nerve testing that's done. I happen to have a printout of one. This is actually an actual patient here. Not to get into too much detail, but what you'd want to see on this test would be as much white color as possible. There is some, and the colors get worse and worse. Black is kind of off the charts. And this is something that we test in the beginning when seeing patients and also throughout care. This is a way to see what's happening with the nervous system and specifically know what's happening. We don't want to guess about it. All too often when patients end up here, previous healthcare practitioners maybe kind of guessed at it or kind of thought they had it figured out. Well, obviously, if you ended up here, it wasn't figured out. So again, that's some nerve testing that we mentioned. History, nerve testing. We then move into, as part of your first evaluation in our office, and every patient goes through what I'm describing. Specific orthopedic testing, specific neurological testing, and also specialized chiropractic testing too as well. All that information is put together and recorded. We also would take x-rays of a patient. We're concerned on how you are in gravity. So your x-rays will be taken standing, and we want to look at the entire spine too as well. So that's how the x-rays are done. We have an instrument here. We have x-rays in the office here. We can actually send x-rays anywhere in the world to the digital system. We can send them anywhere in the world in 5 seconds, literally. So if we needed to send them to a radiologist, we can do that in 5 seconds. If you're moving from Maryland to Florida and you want your x-rays sent, we can send them digitally to the other next doctor you're going to see. So again, that's that. Our real job is to kind of prove that you don't belong here. And we feel as though the screening process that patients go through dictates whether they belong here as a patient or they don't belong here, or which one of the different non-surgical parameters that I mentioned at the beginning, which one of those or which combination of those is going to be best specifically for you. Again, so imagine, I know I've repeated it many times, history, nerve scans, orthopedic, neurological, chiropractic testing, x-rays. Later that night, our doctors get together, study and analyze everything we just described, and then try to come from that, look at that and come up with a decision. Can we help you, yes or no? So what's causing your problems? Can we help you? How long will it take and how much will it cost? Those are kind of the 4 questions that most people want to know. We've got multiple sets of eyes and multiple minds, if you will, studying and analyzing it, looking at it to see what's going on and what will be best specifically for you. That's what happens that night. Very often the first day a person's here during that evaluation process, we'll give them recommendations for that night and have them back the next day or as soon as we can thereafter, so we can answer the questions everybody wants to know. Those 4 questions: what's wrong? Can we help? How long will it take? And how much will it cost? Our results on the far end of the spectrum with regard to decompression and people who are on the far end of the spectrum, our results in the office for that are better than 90%. And again, as I said, the evaluation process history, that dictates which one of the 4 or combination thereof of non-surgical approaches I listed earlier, that all dictates and proves it. We don't guess about things, we test about it. That's the way we've handled things for many, many years. So anyway, that's kind of a synopsis of what I wanted to cover with regard to that, Jan. So back to you.
Great. Thank you, Dr. Cianci. We do have some questions here. So we've got 5 lined up. So let's start off with the first one. First question: why might some of the other back pain therapies I have tried not work?
So with regard to that, let's just say, for example, a person says, well, I did some physical therapy. It used to help. It doesn't help now. Or I've done some strengthening and it's not working. One of the things I think that's not correct there, is not specific enough. Generalized abdominal strengthening, we could all probably use that, but it isn't real specific. It's kind of general. And it's the reason why it's the fact it's general versus very specific that makes it less effective. If you've got a problem that's there long enough and it's affected your body, like I've described here, it's probably just not a little simple strength thing. There's probably more involved there. And if you just work on the one aspect of strengthening your core, it's probably not going to get at the problem. Eventually, the problem will overwhelm the strengthening that you've done. It's just not specific enough.
Great. Question number 2. What would it mean to qualify or not qualify as a patient?
So getting back to the 4 different non-surgical parameters with the decompression, the laser, the rehab, and generalized chiropractic, the evaluation process that I mentioned earlier, that dictates which of those 4 or which combination of those 4 would a person best benefit from. So they could qualify for chiropractic care, let's just say, but we don't really feel like they need laser or decompression. They would qualify, say, for that. Maybe a decompression patient might qualify for decompression. They meet all those parameters. They might have rehab and chiropractic care. So the qualification, if you will, dictates what parameters. The other parameter, the 5th one, is that maybe you don't qualify for anything here. Maybe you need to go get something else taken care of. Maybe you do have to have surgery, or maybe you've got another health issue that doesn't allow you to, quote unquote, qualify for care here. Hence the reason for the detailed analysis and history in the beginning, because we want to make sure the person's in the right place. So we have patients that come in that we send them somewhere else. Yeah, we could probably help them with some of those 4 we mentioned, but we feel as though they need to be evaluated somewhere else. Maybe they need to see another specialist. We've done that. Maybe something on your x-ray that doesn't look right. We don't like it. The doctors here don't like it. And then we maybe send it off to the radiologist, and then the radiologist kind of confirms what we thought, and the person needs to get something else taken care of. So I've spoken about 4. I guess the fifth option would be, no, you need to go somewhere else. And we tell people that too as well.
Great. Third question. What is your opinion on those contraptions you see on TV where people are hanging from their ankles to get the back relief?
Okay. Again, just a little bit of description so our listeners can understand. There are some devices where you may have seen on TV where a person kind of hangs from their ankles upside down. The idea is to get them out of gravity. the thing I don't like about them is this, is that if someone has a degenerating spine, they may have other areas that are degenerating. Maybe they have an old football injury in their ankle. Well, you probably shouldn't hang upside down from that. You may have an old knee injury. You may have a hip replacement, a knee replacement. We don't want people hanging upside down with those issues. And also the idea, again, getting back to the lack of specificity. It's somewhat haphazard. You hang from your ankles, ankle joint's going to separate, knee joint's going to separate, hip joint's going to separate, and then hopefully one or two of the main problems in the spine separate. There's 24 segments, so it's just not very specific. So we have other injuries to be concerned about. Also, hanging upside down is not the best thing for people with heart disease. It's not the best thing for people with diabetes. It's not the best thing for people with hardening of the arteries. We don't really want the heart to kind of work backwards. So there's other issues that can happen. And again, the device that's been described here is something you do at home. It's not under, again, it doesn't have any specificity. It's something done at home. I wouldn't want to have someone doing that without someone there to watch them. And again, it's not specific enough anyway. Specifically with regard to what does a similar thing is the decompression table. We can actually target and get at the specific segment or few segments that need to be decompressed, if you will, rather than just, again, a generalized approach. This just happens to be a lot more specific.
Great. Next question from one of our attendees is, why haven't any other doctors mentioned some of the solutions that you've talked about today?
I think it really gets down to, you can't be an expert in surgery and an expert in non-surgical approaches. There's too much to learn in surgery and too much to be part of. You can't be an expert in drugs and injections and then also be an expert in non-surgical approaches. So that's really what it's all about. Most, for instance, like with me, I feel as though I'm an expert in non-surgical approaches to avoiding surgery for patients. I don't recommend what technique should be used in surgery. I don't tell patients, well, you need surgery, and tell your doctor, your surgeon, to do this technique. It's not my area of expertise. I'm not going to comment on it. So again, there's specialists in surgery and there's specialists in non-surgery. And again, most surgeons know that and don't cross that line, and I wouldn't cross it either. So it's a lack of, you can only know so much. You can't know everything about drugs, injections, and surgery, and also know non-surgical approaches. It's too much to learn.
Great, thank you. Last question. If I come into your office for an initial consultation on this, how long does the first testing appointment take? Sort of what's involved?
Mm-hmm. Just to back up a little bit, again, that's where we take a person's history. We do the nerve scans we mentioned earlier, orthopedic, neurological, chiropractic tests, x-rays and gravity. We look at the whole spine. Our doctors sit down with that later that night. So the time the patient's here, we usually schedule an hour for that. And then the next visit, when we explain it, we schedule usually a half an hour, so we can explain it thoroughly too as well. But the first day, patient could plan to be here for an hour.
Great. That's all the questions we have today. So thank you, Dr. Scianci, and thank you everyone for your time and your participation. If you would like to learn more about the help Dr. Scianci and his team can provide, please call the office at 410-820-4070 or look us up online at drcianci.com/contact us. There's a form online there for questions and for booking an appointment if you so choose. Thank you again for your time and have a great day.